till now we have learned about the basic anatomy of liver, its functions and liver function test. Now a small word about hepatic blood flow and its regulation. Coming to hepatic blood flow, we know that it has dual blood supply, that is portal vein and hepatic artery. Your portal vein is low pressure, low resistance and valvulus. The pressure, it depends on the degree of constriction of mesenteric and splanchnic arterioles and intrahepatic resistance. Okay. Whereas your hepatic artery is high pressure, high resistance. Okay. So how does blood flow to the liver gets regulated is by intrinsic and extrinsic mechanism. Intrinsic mechanism includes your HABR, which is nothing but hepatic arterial buffer response, metabolic control, and pressure flow regulation. Whereas extrinsic mechanisms include neuronal control, humoral control, or your PEEP and IPPV, and also certain surgical factors. So it may include PEEP, IPPV, and surgical factors. Coming basically to HABR, please remember it's a very important topic. HABR stands for hepatic arterial buffer response. So, in the name itself, it indicates that there is something happening in the hepatic artery to buffer something else. Okay? What is happening in the hepatic artery? What is it buffering? That we have to know. If there is some situation in which there is portal venous flow reduction, that means portal blood flow is getting decreased. So, hepatic blood flow depends on your portal and also hepatic arterial blood flow, right? There is decrease in portal blood flow. Obviously, hepatic blood flow also decreases. But hepatic artery does not allow it. What happens is if there is decrease in portal blood flow, hepatic artery vasodilates. So, there will be increase in hepatic artery blood flow. So, this decrease in portal blood flow is compensated by increase in hepatic arterial blood flow, maintaining total hepatic blood flow normal. So, there is decrease in portal blood flow, hepatic artery dilates, so hepatic arterial blood flow increases. If there is increase in portal blood flow, there will be vasoconstriction. That means hepatic arterial blood flow decreases, and final end result is the total hepatic blood flow remains normal. But the vice versa is not true. That means if something happens to hepatic artery, that means if there is decrease or increase in hepatic arterial blood flow due to some causes, the portal blood flow will not change. Okay. Now, why does and how does it happen? Directly that your hepatic artery won't know that okay, portal blood flow is decreased or increased. There has to be some mechanism in between. That is your adenosine washout mechanism. This adenosine from ATP is generally present in the space of mole. Okay, and this has to be washed out by your portal vein and hepatic artery blood flow. If portal venous blood flow is decreased, this washing out also decreases and adenosine levels increases. This increase in adenosine is vasodilated, right? Causes hepatic arterial vasodilatation and hepatic artery flow increases, and thus it compensates for your decreased portal vein. So, any antagonist of adenosine uptake, they potentiate HABR. If they are adenosine antagonists, this is adenosine uptake antagonist. So the antagonist uptake of adenosine, that means adenosine increases. So they potentiate HABR. Direct adenosine antagonists, they block HABR. These are under study still. These are other vasoactive substances which may take part in your HABR, like nitric oxide, carbon monoxide, H2S, and certain neuropeptides. But the most agreed theory is your adenosine washout mechanism. So, where does we see this HABR? What the implications of HABR are in your hepatic resection. That means we have done some partial hepatectomy. The liver mass decreases, but the blood flow relatively increases. This increase in portal blood flow causes portal hyperperfusion, which in turn leads to small for size syndrome later. So, to prevent this, there is portal hypoperfusion, that means total blood flow of the liver is increased. To prevent this, hepatic artery constricts. So there will be hepatic artery hypoperfusion. Total hyperperfusion leading to hepatic hypoperfusion, maintaining the liver blood flow to normal. But if there is more portal hyperperfusion, hepatic artery constricts more to cause hypoperfusion, and this may lead to ischemic cholangitis, graft failure, and infarcts. So we have to control this portal hyperperfusion in hepatectomy patients. That we'll learn it later. Secondly, your laparoscopic surgeries, all the pneumoperitoneum, your position may cause decrease in portal venous flow. Some studies says that this decreased portal venous flow is compensated by increased hepatic arterial flow. Thus, total blood flow is maintained. But some studies say that both portal and also hepatic artery blood flow decreases due to pneumoperitoneum. So, whatever may be, we have to be careful by avoiding more head-up position or preventing pneumoperitoneum greater than 15 mm of Hg so that we can preserve your hepatic blood flow. Coming to inflammatory liver disease, if there is a condition of endotoxemia, there will be decrease of hepatic blood flow in a time-dependent manner. Means in starting stages, there will be dilatation of hepatic artery so that hepatic artery sees that the total blood flow is maintained. But if the endotoxemia persists, there will be ablation of this HABR and total blood flow obviously decreases later. So, to prevent this, some studies say that early administration of NO donor like sodium nitroprusside may stop this ablation of HABR because this nitroprusside maintains your mRNA levels of NO synthetase. So, we are giving nitroprusside, it is maintaining NO synthase levels in the liver. So, there will be restoration of the autoregulatory mechanism of HABR and thus portal blood flow. Even if it is decreased, it is compensated by hepatic artery or dilatation and total blood flow is maintained. Simple, in the starting stages, there will be compensation by HABR. Later, it might not happen. So, finally, liver blood flow decreases. Prevent this, these are still under studies. If we give a NO donor or if we give a sodium nitroprusside, this ablation of HABR may be prevented and the total hepatic blood flow may be maintained. Whereas in your cirrhosis, there will be increased portal resistance and decreased portal blood flow. So, in the same manner, in the starting stages, depending on the severity of your portal hypertension, HABR acts and there will be decrease in hepatic arterial resistance for the increase in portal vascular resistance. So, blood flow finally increases. Some pharmacological modifications of HABR include, we have seen regarding NO. This is regarding adenosine. In porcine model, they have seen that hepatic arterial infusion of this adenosine, it restored hepatic artery flow in the small for size syndrome because it is a vasodilator. So that is about HABR. The other intrinsic mechanisms are your metabolic and pressure flow mechanism. Metabolic control is nothing but if there is increase in H plus or decrease in pH or increase in potassium, carbon dioxide, which are signs of poor perfusion. So there will be vasodilatation. Okay. Whereas pressure flow regulation means if there is increased blood flow. That means pressure in the vessels increase. This is sensed and there will be reflex muscle contraction causing vasoconstriction. So increased blood flow is compensated by vasoconstriction and normal blood flow is maintained. Coming to extrinsic factors, okay. Firstly, neural factors. There are both parasympathetic and sympathetic receptors, okay. Coming to sympathetic response, if there is alpha 1 stimulation, there will be vasoconstriction. If there is beta 2 stimulation, there will be vasodilation. Please remember, alpha is for vasoconstriction. Beta, just remember BB. Beta is for vasodilatation. Okay. Your portal vein has only alpha. So, if that gets stimulated, what happens? Alpha is for vasoconstriction, right? There will be vasoconstriction. Your hepatic artery has both alpha and beta. So that gets stimulated by sympathetic stimulation. There will be vasoconstriction followed by vasodilatation because there is beta receptor also. Okay. If there is parasympathetic stimulation, there will be smooth muscle relaxation. That means vasodilatation and blood flow is increased. Coming to humoral, if there is locally produced vasodilating substances, there will be vasodilation. If there are vasoconstrictor substances, there will be vasoconstriction. Examples of vasodilatory are your bradykinin, serotonin, adenosine, whereas constrictors are vasopressin, neuropeptides, angiotensin 2. And food metabolites causes vasodilatation. That means they increase the blood flow. Okay. And your IPPV or PEEP, obviously they'll decrease your total blood flow. If HABR is intact, there will be your arterial compensation. If that is not intact or there is suppression of that HABR, this causes decrease in your hepatic blood flow also. Coming to surgical factors, this we have discussed, right? In hepatectomy, there will be a small for size syndrome due to increased total hyperperfusion. So they will be doing splenic artery ligation or splenic artery embolization or splenectomy. So this decreases total venous blood flow. So total hyperperfusion is prevented. Thus, your more hepatic vasoconstriction is prevented, preventing your graft rejection or infarcts. Okay. So finally, your hepatic blood flow is maintained by extrinsic and intrinsic mechanisms. So extrinsic are your neural, humoral, or your surgical factors or your ventilatory factors. Intrinsic are your HABR, which is very much important, and the others are your pressure flow regulation or the metabolic control. Okay.